Hi, I am so delighted to meet you in the program of JIP Horse and Heart News. 64 years old male patient with a history of 10 years of diabetes presented with breathing difficulty on exertion and swelling of leg. On examination, we couldn't make any remarkable sign other than swelling of leg. But generally, when somebody presents with breathing difficulty and swelling of the leg, so it is imperative to rule out organ failure. So we have to screen all the organs since organ dysfunctions are known to produce swelling of the legs and breathing difficulty. So in that way, patient was screened for LV function. We did echo. Echo showed absolute normal LV function. So we comfortably ruled out LV failure. Then we did renal function test, that was normal, and we performed liver function test as well, that is also very normal. But what we have to remember that with respect to liver function test, sometimes your liver enzymes may be normal and even ultrasound may reveal normal liver morphology, architecture. But what we have to understand that there may be isolated hypoalbuminemia in the liver function test may point out the origin of pedal edema, because hypoalbuminemia can be due to in the absence of liver pathology. For example, any patient who presents with hypoalbuminemia induced pedal edema, there are three important causes. One starts from the mouth. It may be due to nutritional deficiency, or there may be decreased production due to liver disease, or probably you may be taking normal intake of albumin, protein, and probably your liver synthesize albumin very normally. But because of nephropathy, you may excrete albumin very disproportionately, resulting in hypoalbuminemia. So, in the absence of abnormal liver function, in the absence of kidney pathology, one can have isolated hypoalbuminemia secondary to nutritional deficiency alone. So, in that angle, but in this patient, LFT normal including albumin level. So, renal function normal, echo normal. So, we comfortably ruled out the causes for pedal edema and breathing difficulty. Then our focus shifted towards thyroid function test, which turned out to be normal. Then our focus gradually shifted over his medication. He was on premixed conventional insulin, morning 22 units, night 10 units. He was on pioglitazone 30 milligram daily once, and he was on capsule pregabalin 75 milligram in the night. Then apart from that, he was detected to have rheumatoid arthritis 2 months before, for which he was introduced tablet prednisolone 7.5 milligram, and because of severe pain of late, he was continuously taking NSAIDs for 7 days before he got admitted. So the history was meticulously scrutinized, which revealed that he gained weight about 13 kg over a period of 2 months. So he had weight gain and pedal edema and breathing difficulty. Fortunately, he didn't have any organ dysfunction to be blamed for his pedal edema and breathing difficulty. His thyroid function also normal. Then when we looked at his drug profile, we found that there was deadly combo of drugs resulting in weight gain and pedal edema. He was on insulin and pioglitazone, both are known to produce fluid retention and weight gain. He took steroids and NSAID for past 2 months, known to produce fluid retention. He was on tablet amlodipine 10 mg, known to produce fluid retention. And in fact, he was on pregabalin also. And sometimes many literatures reported that pregabalin can produce fluid retention. So, once we concluded that it is absolutely this weight gain and pedal edema due to this deadly combo, then we switched over to premixed insulin analog rather than for conventional insulin, and pioglitazone was stopped. Patient was introduced SGLT2 inhibitor to counteract pedal edema and weight gain, and amlodipine was switched over to ARB, telmisartan, and pregabalin was stopped, switched over to duloxetine. Then, of course, this steroids is an part and parcel of rheumatoid arthritis, and he was taking only 7.5 milligram, that is known to produce less weight gain. And in fact, probably the NSAID intake recently he had taken, which might have propelled everything into larger part of the picture. So once we stopped, then we switched over to alternative regimen. Then we started in loop diuretic, preferably furosemide. Then, the loop diuretic was given in the form of intravenous. Then within 48 hours, we were able to achieve 5.5 kg weight reduction. Then patient was reviewed. Then after 2 weeks, we were able to bring down another 3 kg, totally 8.5 kg weight has been reduced within these 2 weeks of span. So now we have to understand that this pedal edema and weight gain, it is not only breathing difficulty, it is not only due to pathological disease, it may be iatrogenic as well. So how insulin produces pedal edema? Insulin is known to activate sodium potassium channel and sodium H plus channel in the proximal tubules of the kidney, by which it promotes sodium and water absorption. Apart from that, this conventional insulin can produce hypoglycemia, which can result in frequent snacking, resulting in overweight and weight gain. And pioglitazone is known to produce many adverse effects, not only weight gain, it can precipitate cardiac failure, it can induce fractures in postmenopausal women, it can precipitate macular edema. So the most important thing is, it also promotes or activates epithelial sodium channel in the collecting tubules, by which water is absorbed in our body, by which it promotes water absorption. Even though proactive study promotes pioglitazone because of non-significant 10% reduction in macrovascular event, even during secondary prevention of clinical atherosclerotic cardiovascular disease, but since it exerts multiple adverse effects, including controversial bladder CA, even though that has been silenced in 2017 with the meta-analysis of various studies, since it evokes many adverse effects, so it is very prudent to introduce pioglitazone, preferably lower dose like 7.5 milligram. Then another important is amlodipine. Amlodipine is well known to produce pedal edema, but we can use off late, we can use the 4th generation calcium channel blocker, cilnidipine can be used, because amlodipine acts only at L-type voltage gated calcium channel. So it exerts impact on vasculature, resulting in profound vasodilatation, produces edema. On the other hand, cilnidipine acts at both L and N type of calcium channels. So you have two types of calcium channel. One is L type and N type. L type calcium channel present only in the vascular system. The N type calcium channel present in the presynaptic neuron. So cilnidipine not only inhibits the L type calcium channel, it inhibits N type calcium channel as well. The advantage of inhibiting N type calcium channel is because of inhibition over N type calcium channel that are present in presynaptic neuron, resulting in decreased delivery of noradrenaline. So that's the reason there is so much reduction in incidence of tachycardia in the case of cilnidipine as compared to amlodipine. And apart from that, since it reduces the discharge of noradrenaline thanks to inhibition over N-type calcium channel, it causes much more impact in CV protection and as well as renoprotection. It has been found that because of additional inhibition over N-type calcium channel, it produces robust cardiovascular protection and as well as renoprotection as compared to amlodipine. Then apart from that, this sympathetic discharge is always implicated in early morning hypertension and white coat hypertension. That's why cilnidipine is recently advocated in early morning hypertension and as well as white coat hypertension. So there are few incidents of pedal edema in the case of cilnidipine as compared to amlodipine. But when you don't have any choice in replacing amlodipine with any other class of calcium channel blocker, then you can replace with cilnidipine in the case of amlodipine induced pedal edema. Then apart from that, the patient is taking capsule pregabalin. So clinically, we are not witnessing much pregabalin induced pedal edema and weight gain, but literature clearly says that there are many incidents of pregabalin induced pedal edema and weight gain. So probably when you come across any diabetic patient with unusual weight gain and pedal edema, and even after exclusion of other causes, probably you can think of pregabalin induced pedal edema. The mechanism that lies behind pregabalin induced pedal edema is something like it is akin to or similar to calcium channel blocker. It also stimulates L-type calcium channel in vascular endothelium. So it inhibits L-type calcium channel by which vasodilatation occurs, resulting in pedal edema. Then apart from that, patient was taking steroid, but larger dose of steroid for longer duration known to produce weight gain. But sometimes even the trivial dose also can produce pedal edema. It's all based upon the genetic variation of the patient. But generally most of the steroids carry mineralocorticoid activity. Any steroid tablet that carries glucocorticoid activity and mineralocorticoid activity. So when you administer steroids by means of glucocorticoid activity, it exerts anti-inflammatory action, it exerts immunosuppressive action. At the same time, when you have mineralocorticoid activity, what happens? It promotes water and fluid retention. So that's the reason when you have cerebral edema, we prefer dexamethasone over hydrocortisone, because any emergency, any allergy, we give hydrocortisone. Any acute severe asthma, we give hydrocortisone. But in cerebral edema, we prefer dexamethasone over hydrocortisone because hydrocortisone contains significant amount of mineralocorticoid activity resulting in fluid retention. That's the reason we don't want to aggravate cerebral edema by giving hydrocortisone in the case of any type of cerebral edema. On the other hand, dexamethasone contains least amount of mineralocorticoid activity resulting in less amount of fluid retention. So this is the way steroids causes fluid retention. Then apart from that, NSAID, this patient last 1 week because of severe joint pain, he took NSAIDs. NSAID reduces the prostaglandin production in our body, which has huge ramification over kidney. The first most important is when you reduce prostaglandin production in the kidney, that causes decreased renal blood flow, resulting in increased proximal renal tubular sodium absorption. Apart from that, there is increased chloride absorption in the loop of Henle. There is activation of RAS system, because of which all of these things causes sodium and water retention, and to large extent it can aggravate blood pressure. So after concluding that all these drugs were very capable of producing weight gain and fluid retention, resulting in breathing difficulty, then we removed and we changed these drugs, following which patient gradually recovered. Thank you.